be published on FlightCrit at flightcrit.com/webinar replay. And you'll be able to find that there. If you pop in and you have to leave for whatever reason, you'll still be able to catch the follow-up either over there on the website, or it'll be up for a little bit here on Facebook. Okay, so let's get started with neuro. So let's see here. Okay. So you should see here the landing page for the neuro emergencies section. There we go. Boom. Okay, that popped up. Excellent. And just going to make sure that everything is looking good. All right. So I am not going to be going through the entire lesson. As you can see, there are 124 slides in this lesson. I am going to start going over just kind of the big stuff that's really going to make a difference in your scores on the exam. There's going to be a ton more content within the course. So you're still going to want to come back and go through those lessons, but this should really help those of you who are getting ready to sit down for the exam. So objectives that are going to be covered in the course, you can see them here. We're going to go over a lot of stuff, neuroassessment, reviewing coma, that's specifically on the outline for the exam. Talking about medications, seizures, strokes, intracerebral hemorrhage, spinal cord injuries, and ICP monitoring. Some of these will be a lot more in-depth than others, but it'll all be useful not only for the exam, but also for just your practice in general. Okay, so just kind of skipping through some of the anatomy stuff right off the bat. Make sure that you're doing a thorough review of the anatomy and physiology of the nervous system, because that's going to set the foundation for a lot of the other information, a lot of the other questions that you're going to see throughout the course, as well as throughout the test. So make sure you are doing a thorough review of the CNS anatomy. Something that you may not be aware of, there's this term, this tentorium cerebelli. Okay, what this is an extension of the dura mater. And as we're going to talk about here in a little bit, the dura is comprised of two separate layers, and that inner layer creates this tentorium cerebelli. And what this is simply a fibrous membrane that separates the cerebrum from the cerebellum. Okay, and this tentorium cerebelli is this region right here, and it surrounds the spinal cord as well. So you can see this section here surrounding the spinal cord is called the tentura insensura. Okay, and you may hear questions on the exam that refer to something as being supratentorial or infratentorial. Okay, now anything that is above this tentura cerebelli is considered supratentorial, and below it, of course, is infratentorial. And that's going to be important when we talk about ICP and herniations. Okay, so just keep that in mind. Okay, remember you've got your various regions, your different lobes, your four lobes, and they're in pairs, and then you've got specific regions within the lobes that perform different functions. They do like to hit on this Broca's region and the Wernicke's region, which I'm sure you're all very familiar with, but just remember that the Broca region is primarily responsible for the formation of words. So if somebody has suffered an injury to this Broca region, which is in that frontal lobe, they'll have a difficult time with expression, or this expressive aphasia. Okay. Sometimes you may hear this referred to as Broca's aphasia. Okay. This Warnicke area, okay, this is back in the temporal lobe, and this is responsible for receptive. And it's not just auditory, but it's also visual reception. So as the eyes take in the external stimuli, it's processed through the Warnicke's area, and then it's sent up to the Broca's region for communication. So there's this communication back and forth between the Broca's region and the Warnicke's region. Okay, so just be aware of that. The limbic system, review that a little bit because they do like to talk about behavioral complications associated with strokes. We know this limbic system is connected with the brainstem, and it's responsible for emotion and kind of processing of information. So there is this phrase, right? We all hear about coma, and when you sit down to take the exam, it's going to be important to be able to differentiate coma from other levels of altered mental status. And remember the reticular activating system, okay? It's this network of neural fibers that encompasses the brainstem as well as regions within the brain. And they call it a system because it's not necessarily specific structures per se. It's more, let me see if I can move this up out of the way. So, let's see, how do I, there we go. There you go. That should get that up out of the way. You can see this a little better. So it's a system because it's not necessarily like specific structures. It's just kind of a network of neural fibers that run up through the brain, and they're responsible for this awakeness and this alertness and consciousness. So when you are assessing a patient, it's important to be able to distinguish between an injury that which portion of the reticular activating system is damaged. Okay, so let's just talk about this in a little bit more detail for just a second. So depending on the region, you can have unconsciousness or you can have alertness but no awareness. Okay, and that's the persistent vegetative state that you will sometimes hear referred to. Remember, oh gosh, there was the Florida woman back in the, oh gosh, I'd have to look up exactly when, but I believe it was the early 2000s, named Terry Schiavo. And it was a big battle between her husband and her family about whether or not they should continue to maintain life-sustaining care. In her case, it was like tube feeds. Okay, and the doctors were saying that she was in this persistent vegetative state, that she had suffered such massive damage to her reticular activating system that she was alert, but she was not aware. And the family argued, no, she has these intentional responses. She is aware. She does know what's going on. And so there was a battle. There was a debate between whether or not this was somebody who was actually aware of what was going on with her surroundings, or if it was just simply those primitive responses. Her breathing was intact. Her eyes were open. She had this sense of awakeness, but she was not aware or alert. And so that is a different region of the reticular activating system that is damaged. Okay, so let's look at this. So this it's the upper region, which is primarily housed within the thalamus. That is responsible for the alertness and the focus. And then, of course, the brainstem we know is responsible for consciousness. So if somebody has damage to the thalamus, that's when you'll see this persistent vegetative state. This is their eyes are open. They'll have normal sleep-wake cycles, but they will not have this awareness. Whereas somebody who has damage to the brainstem, of course, those are the patients who have this total loss of consciousness. Okay. So that's kind of the differentiation between coma and then, well, kind of varying degrees of coma. Spinal cord anatomy, remember, make sure you kind of do an overview of spinal cord anatomy, anterior, posterior, and central canals. You have your afferent and your efferent nerve fibers. Remembers which ones send signals to the muscles and which ones receive signals from the muscles. And then there's also this pre and post ganglionic, you've got the preganglionic. Oh my goodness, why am I drawing the preganglionic motor neurons and the postganglionic upper and lower motor neurons. And the upper motor neurons, where do they desiccate? Where do they cross over within the spinal cord? That's going to be very helpful when you actually start thinking about spinal cord injuries and things like Brown-Sequard syndrome and the other spinal cord syndromes, when you're trying to figure out, okay, why do I have loss of sensation on one side and loss of motor on the other, okay, or fine vibration on the other. It's going to help you kind of make sense about why those spinal cord injuries present the way they do. Remember your basic spinal cord injury or spinal cord anatomy, which is the number of nerve tracts. You've got 32 pairs of spinal nerves. They correspond to different regions of the body. Okay. So again, continuing just this basic overview, you've got the meningeal layers, you've got the dura, arachnoid, and pia. The dura matter is two dural reflections that are kept together. That's why you have this epidural. That's why you have these dural reflections. So you have these fissures, right? You've got this longitudinal fissure that runs down the midline of the brain, and within that fissure, you've got the cerebral cortex. You've got this my goodness, I'm drawing a blank here, and I'm sorry about that, people. You've got the region where the CSF flows, okay, and that is established, that is created by this extension, this reflection of the dura mater, okay, down into that longitudinal fissure. Likewise, with the tentorium cerebelli, right? You've got this extension of the dura mater that separates the cerebellum from the cerebrum, and it creates this space. It creates this separation. Some other things to note about the dura is it is actually connected to the underside of the cranium or of the skull along suture lines. Okay, so when we start talking about epidural bleeds and subdural bleeds, what you should notice when looking at scans is that an epidural bleed should not cross suture lines, because that is where the dura mater is adhered to the skull. Now, if you have like a linear skull fracture that crosses the suture line, then that can actually compromise that adhesion to the underside of the skull and can actually allow for a greater extension of that epidural bleed. Okay, so CNS anatomy continued. You've got your brain, of course, and we're going to talk about the Monroe-Kelly doctrine and how that relates to ICP. But to understand a little bit more about how the Monroe-Kelly doctrine and ICP management compromises the cerebrum, it compromises our brain. We need to understand a little bit more about cerebral spinal fluid and its production and blood flow and so on and so forth. So CSF is produced in the coracoid plexus, which is in the lateral ventricles up here. You have 4 ventricles. You've got the left and right lateral ventricle. Then you have the third ventricle, which sits down here in the midline. And then you have the 4th ventricle that sits down even farther, just right about the level of the cerebellum. 70% of your CSF is produced in the coracoid plexus, and then the remaining 30% is produced elsewhere in the CNS. Okay, cells of the ventricles down here in the 3rd and 4th ventricle, as well as in the blood vessels. The thing to note about this is, well, a couple things. First of all, the coracoid plexus produces about 500 mLs of CSF every day. And it's produced at a relatively constant rate. At any one time, you have about 150 mLs of CSF within the central nervous system, and about 50% of that is up in the head. So at any one time, there's about 75 mLs of CSF that is housed within the head. And so when, excuse me. Pardon me. Okay, so when you have an insult to the head and the brain starts to swell, right, we have this Monroe-Kelly doctrine that says that, you can only have a certain amount of space within an enclosed, or a certain amount of volume within an enclosed space. And within the head, we've got brain tissue, we've got CSF, and we have blood. Well, there is no feedback mechanism to stop the production of CSF. So, what is this? Sorry, everyone. If your brain is swelling, then through autoregulation, your blood vessels are going to try and constrict, but the CSF is still being produced within those ventricles. So you're fighting this losing battle almost. You've got the ventricles constantly producing more CSF, even though you're trying to minimize the amount of volume within the brain to make room for that swelling of the brain tissue. Okay, so that's why if you're putting in a ventric, so a ventricular drain, then you can get away with pulling CSF off at a constant rate. And so you'll see in the ICU where the patient will have a ventric placed into the ventricles to drain CSF and monitor their ICP. They may they'll set the scale on that to drain CSF at a constant rate. Okay, and so the idea is to slowly drain the CSF off to bring the ICPs down, and then eventually, once the swelling has slowed, then they'll reduce the rate at which the CSF is drained off to match the rate at which the CSF is produced, so that you're not allowing that the ICP to spike again. Ooh, that was a lot to cover on that one slide. So we already talked about this. You've got the ventricles left and right. They're connected to the third ventricle by the foramen of Monroe. The foramen of Monroe is the point at which you're going to level your transducer if you are trying to monitor ICPs. Okay, and that is consistent with the external auditory canal. And there's a better image that'll show that here in just a little bit. And then you have the cerebral aqueduct that connects the third and fourth ventricle. And then you have the subarachnoid space and the arachnoid granulations, or the arachnoid villa. And so this is important to realize. If you think back to the trauma section, I talked about how one of the best ways that we can improve ICPs in a patient with a head injury is to sit them up. And what that does is that promotes drainage from your internal and external jugulars. Okay, this is why that helps to drain or to minimize ICP, because you have this CSF that is produced within the lateral ventricles, right, and it circulates around the spinal cord and cerebellum, and eventually it goes through these aqueducts into the subarachnoid space. Okay, you can see it passes through these arachnoid granulations. And it gets reabsorbed into the cerebral venous system here within the arachnoid, the subarachnoid space. I'm sorry, just outside the subarachnoid space. Okay, so you have these granulations. Let me zoom in here a little bit and show you what I'm talking about. Okay, so you have here the subarachnoid space, and then there are these arachnoid granulations that extend across the dura and protrude into this sagittal sinus. And this is where the CSF is reabsorbed back into the venous circulation. Okay, so remember I mentioned that cerebral perfusion pressure is mean arterial pressure minus ICP, okay, or mean arterial pressure minus central venous pressure. And that should make a little bit more sense now. You'll never see it calculated using central venous pressure. But in reality, if your central venous pressure is exceptionally high, that's going to impede venous drainage back into the central circulation and will impede this CSF reabsorption. Okay, you've got your internal cerebral circulation, your common carotids, your internal carotid arteries, circle of Willis, right? We know that there's a lot of cross communication, collateral circulation, if you will. And what you may remember from the last section on critical cardiac, I mentioned that if you have this aortic dissection, or if you have a patient with a balloon pump in, and that balloon pump migrates proximally, right, and it obstructs this left subclavian artery, well, what else is it obstructing? It's also obstructing this left vertebral artery, which supplies blood flow to the posterior brain and eventually communicates with the circle of Willis and provides a collateral circulation to the rest of the body. But if you think about this, you've got your left common carotid that comes up here, and that's feeding into the superior portion. And you've got the opposite side, the contralateral side, that's providing blood flow. But if you obstruct this left vertebral artery, then you're obstructing potentially blood supply to the spinal cord, and then also kind of on this ipsilateral posterior side of the brain is going to kind of become ischemic sooner rather than the rest of the region of the brain. So you may have stroke-like symptoms if you have a patient who has a dissection that has crossed that left subclavian and is reducing blood flow to that left vertebral artery. Of course, the one that they like to throw in there for your epidural bleeds is your middle meningeal artery. This is the primary artery that's responsible for those rapid declines or that cause epidural bleeds. And the primary reason for that is it's very exposed. Let's take a look at this. It's right here in the temporal region, and I'll zoom in here a little bit and show you. You'll be able to zoom in as you're going through the material. Remember, I post the slide decks so you can look at them very closely. But here you have, this is the middle meningeal artery that comes off right here. Okay, it's kind of hard to see middle meningeal artery here, but that's this one right here, and it actually travels along the exterior surface of the brain, right along the skull. Okay, you can see it runs up, and then here it branches off, and it spreads out throughout the temporal region of the brain. Okay, so that's why, and it's right on the surface. It's right. It's very superficial to the brain. So that's why if you have an injury to that temporal region, and you, of course, it is arterial, right? So it's going to bleed a lot. That's why you get these epidural bleeds can cause. That's why one of the biggest causes of these epidural bleeds is trauma to this middle meningeal artery. All right, let me go ahead and see if I can. Oh, that's not what I want. Give me just a minute here, and I will see if I can improve the connection. Okay, I'm going to pause here for just a second and see if there's any questions, if there's anybody that's watching live on Facebook or actually here in the chat, and see if there are any questions. To kind of let that soak in here for just a minute. Okay. I'll just kind of throw this in there right now. For those of you who are going to be catching this on the replay, in the future, or anybody who's listening right now, so you can actually join in the webinar over at, what is it again? FlightCrit.com/ask flight. No, chat with crit. FlightCrit.com/chat with crit. And I put that in the announcement for the lesson. Okay. So now we're going to talk about like I said, the cerebral venous drainage. We were talking about this before, and how there's the dural venous sinuses and how these drain into that internal jugular. Okay, so here are your primary dural venous sinuses. You've got the one that circulates up here around the crown, and these all basically circulate back here to this confluence. And then from here, you've got this transverse sinus, which is deep within the brain, and that's where it drains back into the great cerebral vein, drains back into your internal jugular. Okay, so when if you have an obstruction anywhere within this venous circulation, that can cause increased ICP. One thing that I wanted to mention earlier, I'm going to go back real quick just to kind of hit on this. We're going to talk about this more when we when we get to ICP management. But remember what I was saying. You have. Let me find the proper slide for this. Well, anyways, this one's going to work really well. So you've got the cerebral aqueduct, and if you have blood within the third or the fourth ventricle, okay, that's a lot riskier than having blood up in the lateral ventricles. Of course, it's never a good thing to have blood anywhere in the head where it's not supposed to be. But if you have blood within these third or fourth ventricle, then you're far more likely to have an obstruction of those cerebral aqueducts and thus obstruct outflow of the CSF, which of course is going to add to the ICP. Okay, so if you are doing a transport and you happen to look at the CT or MRI and see blood within that third or fourth ventricle, or you read in the report that there's blood in the third or fourth ventricle, just understand that that's going to confound your ability to manage their ICP, or you just may need to be a little bit more aggressive. Okay, and then this is just another image that shows you how these right internal jugular veins and then just kind of come down and drain into the subclavian. But this is coming down from the cerebral venous circulation. So when you're assessing your neuro patient, right, it's no different than the assessment that you've been doing for your entire career. But there's just a few other things to be looking out for. So, right, we look at pupil size, but what does pupil size really mean? Well, it could be completely benign. They could just have a history of unequal pupils. Or in the setting of this neuro patient, it could be compression of that optic nerve. So when we get to talking about ICP, we're going to talk about the uncal herniation. Okay. My whole career, we talked about, these patients who are herniating, and there was this belief that the brain was herniating down through the forma magnum and was being squished out the bottom of their skull. And while that, not literally happens, but you do get pressure that could try to force your brain down and do damage to the inferior portion of the brain. What happens more often is this uncal herniation, where the uncus, which is supratentorial, tries to get forced down through that tentorial insensura. And when that happens, it compresses that optic nerve. And so that's when you start getting that blown pupil. Okay, so the blown pupil is a sign of typically uncal herniation, as the brain is trying to, is squeezing through that or down into that tentorium insensura. Okay, not necessarily the forma magnum. As far as seizures go, if you're taking care of a trauma patient or any kind of neuro patient, it's important to ask if they've had seizures. Generally speaking, there's less of an inclination to give these seizure prophylactic medications unless the patient has already had a seizure, which seems really kind of counterintuitive to me. But in any case, that generally is kind of what happens. Is if the patient hasn't had a seizure, then what the evidence is suggesting is that giving prophylactic seizure medications doesn't necessarily do any good. What else do we want to mention specifically about seizures and your assessment. Brain injury, tumors, AVMs, things like that. Does the patient have a history of arterial venous malformation? When were they last seen normal? Of course, that's important. Did they have any complaints of headache, recent trauma? The recent trauma question sometimes gets overlooked when you're managing a patient who's had a recent seizure and there's no immediate acute trauma, like they didn't just fall and hit their head. But it's important to realize, in the subarachnoid space, that's mostly venous blood flow, so it's slow, and there's a lot of space in there. So kiddos and elderly adults whose brains have atrophied a little bit, they can actually have a lot of extra space within that brain. So you can have this slow bleed that progresses over days or even weeks, and now they're having seizure activity associated with increased ICP from this slow venous bleed from a fall they had 2 weeks ago. So just make sure you're asking about trauma when you have these neuro patients, especially if they fit into one of those two categories, either the very young or the very old. Mental status change is generally the first sign of head injury and increased ICP. So even if they don't have a recent history of trauma, if there's any indication that maybe they are suffering from elevated ICP or neuro problem from a spontaneous bleed, ask about mental status change, or I guess the opposite would go, if somebody's has this acute unexplained mental status change, it could be from a spontaneous bleed. We talked about cranial nerve 2 from ICP. So it's going to cause ipsilateral pupil dilation. So pupil dilation on the same side of the brain as the insult occurred. And then you'll have contralateral deficits because of that desiccation, that crossing over of the upper and lower motor neurons. Okay, so to be honest with you, it wasn't until I started researching for this section that I stumbled upon this, and it kind of makes sense. In paramedic school, we're always taught, when you're asking somebody about their mental status, person, place, time, and event, or person, place, and time, times 3, person, place, and time. And I don't know if it's just coincidental or if it actually has any kind of significance, but we know that a patient who is suffering a neurologic emergency, they will have a loss of awareness in a very predictable pattern, or a loss of orientation in a very predictable pattern. So first they will they will experience a loss of awareness of time, followed by place, followed by person. So when asking somebody person, place, and time, what's your name? Who is, do you know this person standing next to you, your spouse? Do you know where you are? Do you know what time it is? Do you know what date it is? By asking in that order, what we're essentially doing is we are coming up with an idea of how severe is their handicap, how severe is their injury, is their condition. If they have no idea of who they are, you can assume that that's much more severe. But if they know who they are and they know where they are, but they just can't remember the date, well, yeah, they maybe they just don't know the date. I mean, half the time I don't either. But perhaps they have a mild insult that is exhibiting itself through a loss of awareness of time. Hey, Daryl, what's up, buddy? Thanks for jumping in. Glad to see you here. If you missed, you didn't miss a whole lot, but you'll be able to catch it on the replay. It'll still be here on Facebook Live for a little while, and then eventually I'll move it over to the website at FlightCrit.com/webinar replay, and you'll be able to find it there. Okay, so your AVPU and your GCS, right? Just remember to review those, especially your GCS. Make sure you're able to calculate an accurate GCS. That does show up on the exam from time to time. There's something that I wanted to touch on, and I'm going to take this opportunity to that. Over the past several years, I've noticed that when you're I've noticed students or other EMTs talk about the AVPU scale, and they end up there's a confusion about classifying somebody as alert to painful stimuli only. Okay, in order for somebody to be considered responsive to painful, what you're trying to elicit is a purposeful response. So if you have somebody who's unconscious, unresponsive, and you sternal rub them and they posture, that's not, they're not responsive to painful. Okay, they are unresponsive. And then you need to differentiate how unresponsive they are using the Glasgow Coma Scale. Okay. If you were to sternal rub them and they would open their eyes and say, ow, that's a purposeful response. And that's one that would get them classified as a alert to painful stimuli, not a decorticated cerebral posturing. That's not an alertness. Okay. The other thing is the GCS, that is a trauma assessment. So we use GCS a lot in assessing non-traumatic patients, but in reality, the Glasgow Coma Scale is a trauma assessment. And so whether or not it's actually a good representation of somebody's mental status when they have a medical emergency is open for debate. I'd be interested in seeing some more specific research or finding any kind of research that specifically looks at the efficacy of using Glasgow Coma Scale for the assessment of a medical patient. If you are assessing a neuro patient, in reality, if it's not a trauma, then you should be using something like the Cincinnati Pre-Hospital Scale or the NIH scale or the MEND. The NIH is the gold standard, and there will be, I believe I've got a link in here. If not, I'll put it in the comment section. But there actually is a NIH certification class. It's an online certification that you can obtain. I think I put it in here. I'm going to do a quick look real quick, and I'll put it in the comment section for everybody. Certification. Let's see here. Okay, cool. Here we go. Copy. Okay. So I just put in the comment section here a link that you can use in order to get to the NIH stroke scale online certification class. It's a good thing to, I think it's a good thing to go through. If you haven't been through it before, check it out. You can get a little certificate, take it to your employer and impress them if it's not a requirement. Okay, so we already talked about coma, a loss of alertness versus the loss of awareness. There are the AIOU tips, which are differentials for coma. We all know those. Don't forget about your metabolic derangements. Within the exam, so you may see questions that pertain to dermatomes. So an injury at C4 correlates with the shoulders. T4 are the nipples. T10 is the umbilicus, and then S1 is the little toe. Why on earth they throw a little toe in there is kind of beyond me, but these are the dermatomes that I've seen on my past exams and that I have heard others refer to or mention that they saw on their exam as well. C8, C8, I don't know. Oh, C8. So C8 small finger. I actually have heard that. So the inside of the arm, differentiating the inside of the arm. The patient has preserved function or sensation of like their thumb. They can feel everything just fine, but they've got some numbness to their pinky finger, and that can differentiate a C5, C8 injury. Of course, you've got your different specific ocular findings, ocular cephalic reflex. They do throw in there every once in a while, and this is that doll's eye. This is that patient who's sustained pretty significant damage to this brain stem of this cerebellum, and this is that patient who, if you were to take their head and you were to turn their head from side to side, their eyes they don't track. So, like if I turn my head, you can see that my eyes move the opposite direction. That's a normal response. If if I turn my head and my eyes didn't try to track, they stayed midline. That's the oculocephalic reflex, and that's a pretty ominous finding. Horizontal gaze preference. So you've got your disconjugate gaze, failure of the eyes to both sides, failure of the eyes to focus on the same object. So one eye is looking forward, the other one's looking a different way. That's a brainstem lesion. As far as gaze preference goes, this comes up every once in a while. So I always think about it as like you want to get away from something that's irritating, and blood is very irritating in the head, especially in the head and in the GI tract. So if somebody's got a conjugate gaze to the left and they've sustained a big blow to the right, suspect bleeding in their head. The eyes are going to look away from something that's irritating. So expect that there's blood up in the head on the right side if the eyes to the left. Now, the other side of that is the eyes will have a tendency to deviate towards a destructive lesion. So somebody who has an ischemic stroke or a tumor, okay, some kind of mass space occupying lesion, so a tumor, the eyes will look in the direction of the lesion. So that will kind of help guide you. If you've got somebody who's got some kind of we know that ischemic strokes, somebody with a history of AFib and a sudden acute onset of stroke-like symptoms, and their eyes are deviated to the right, you could expect, and they've got left-sided, deficits. You could expect, that's just another way, to kind of clue you in that, this is probably an ischemic stroke. Talked about the oculocephalic reflex. Okay, let's see. Where are we now? Your motor function and reflex test. This is going to be important for scaling. Not so much on the exam. What you will see on the exam, and this is kind of getting into upper and lower motor neuron deficits. But sorry, I just needed to take a look at what I thought was a comment that popped up here. And I keep forgetting that the camera is attached to my computer. I think what I'm going to end up having to do is get myself a better camera so that I stop doing that. So I apologize, everybody. I'm going to try and scale this up so I can see more. Okay, so I'm not going to go into full assessment of upper and lower motor neuron deficits. But what I will tell you, and we'll look at it in a couple more slides, is that upper motor neuron damage tends to cause spasticity, so like clonus. Whereas somebody who has sustained a lower motor neuron injury, that will tend to cause flaccidity. So keep that in mind as you are going through and studying about these different upper and lower motor neuron injuries. It's because how do I describe this? When it comes to the upper motor neurons, they serve two different roles. So not only do they stimulate a reflex, but they also carry the inhibitory signals for that reflex. Once the signal gets down to the lower motor neurons, those are primarily responsible for stimulation. Okay. And if you think about that, that makes sense. If you want your arm to contract, it takes an impulse. Okay. But if you want your muscles to relax, that's a passive response. It takes a signal from the brain down to that lower motor neuron receptor site to tell that lower motor neuron to stop firing. Okay, but once that lower motor neuron is no longer getting a signal to contract, it just relaxes. So that signal to relax or that signal to contract comes from the brain. Okay, but in the lower portion, it's the absence of a signal to contract that causes relaxation. I hope that makes sense. I'm watching the video here and it seems like there's some lag. I'm going to have to try and work that out. Let me see if I can reduce the resolution. It's probably trying to increase the resolution. Let's see if I can improve this. That's probably a little bit annoying, isn't it? Let's see what happens if I do this. HD is turned off. Let's see if that changes, if that improves the quality of the stream. Just by I made a couple adjustments here. Hopefully, I'll go back and I'll watch the preview afterwards and see how that does. So detailed neurologic exam, we already talked about that a little bit. And then here in the course, I go into a little bit more about the upper motor neuron. And just real quick, you can see here that there's this so this one here is the upper motor neurons, and you get this crossing over. Let's take a look here real quick. So with the upper motor neurons, everything is heightened. Okay, so you have both the afferent and the efferent signals coming down. This here is your I think I have an error here, so I'm gonna have to fix that in the slides. But everything here is normal. This here, I believe, is a little bit goofed up. So don't worry about what you see here, but just pay attention to what you see over here. In that, with the upper motor neuron, everything is heightened, and then here's kind of an explanation of where these upper motor neuron fibers originate from, and then where they are intervening. Yeah, they're innervating the spinal cord and where they synapse. And then same goes for the lower motor neuron. Everything is suppressed. If you do this NIH stroke training, you'll learn about this. But when you are doing your sensory exam, make sure that you're having your patient's eyes closed. that's going to avoid any visual clues. It's going to skew your assessment, okay? And you want to be checking all of these different things. You want to be checking bilaterally for comparison. You want to start distal and work your way proximal, okay? Because if there's an injury down low, you'll find it quicker if you work your way from the distal to proximal, okay? Because of just, if you touch somebody on their feet and their sensations intact, or their pain's intact, or they can move their toes, then you know that basically they definitely don't have a C5 injury, okay? But if you were to check somebody's face and it's intact, well, now you got to keep checking down farther and keep hunting for that line of demarcation, okay? If you have a suspicion of where there might be a deficit, start there, okay? The whole idea is to narrow down where this line of demarcation is as quickly as possible. Of course, we know about your cranial nerves, and there's the whether or not it's a sensory or motor. Right? So sensory, motor, both. You understand that sensory, motor, both, sensory, both, motor, and that corresponds with 1 through 12. In the course, I'm going to give basically a quick rundown on how to do a quick neuro exam. But we probably all know this, off the top of our head. But checking pupils, checking visual fields, eye movement, have the patient close their eyes tightly, raise their eyebrows, blow their cheeks out, stick their tongue out, shrug their shoulders, say ah, and then there's also extension and flexion of their arms, and fingers as well. Have them spread their fingers out against resistance, and that's going to help basically hit your full 12 spinal nerves or cranial nerves really quickly. Okay, I'm just kind of doing a quick look here. Seizures. All right, so we'll go over seizures real quick, and then we're going to call it for this broadcast. This has been going on about an hour now. Seizures, of course, just having a general idea of what causes them. Sometimes they're idiopathic, like epilepsy. They can be caused from trauma, strokes, metabolic disorders, infections. And then there's this vasovagal seizure, which really isn't true seizures. It's just a vasovagal response. You bear down, blood pressure drops, the brain becomes hypoxic. You have this brief period of hypoxia, and there's some tonic-clonic-like activity, but it's not a true seizure. We know how to manage these if they are, in fact, status, benzodiazepines. As far as metabolic disorders, of course, we need to correct whatever metabolic disorder is causing the problem. Infections, always going to be antibiotics, and then manage them symptomatically. Of course, trauma, we need to expect that this is an elevated ICP. We need to manage that ICP with proper positioning, reduction of stimulus, and then, our other tricks that we might take or we might use to manage ICPs, like sitting them upright, hyperventilation if there is a suspicion that they are herniating with like the Cushing's reflex, Cushing's triad, and blown pupil. You've got hypertonic saline or mannitol to try and control those ICPs. And then if this is an ICU patient that you're transferring and they happen to have a ventric, if you've got orders for reducing or for draining CSF, that might be part of your treatment goal. Of course, it's always going to be manage the seizure first with benzodiazepines, control the seizure activity, because we know that seizure activities causes a massive increase in cerebral metabolic O2 demand, and results in a lot of metabolic waste that can just compound the injury. Like I just said, increases cerebral metabolic demand, so it can cause things to be worse. Now, the greatest risk for seizures is within the first 24 hours of the injury. We talked about benzos, propofols, Keppras, and barbiturates are some of your other seizure medications that you may use. Of course, the first line is always going to be your benzos. It's because it's the fastest and easiest to administer. So at whatever you prefer, Ativan, Versed, or Keppra. Keppra is used in some patients for the acute management of seizures. It's also frequently used for prophylaxis. So you may see that for both incidences. And there was a funny thread recently on Facebook where in the manual, actually the manual that I use a lot for my practice and for this review course, it said that benzodiazepines inhibit GABA, and that's actually incorrect. GABA is a neurotransmitter in the brain that induces a state of suppression. It's an inhibitory neurotransmitter. So alcohol, benzodiazepines, those type of medications, they actually increase the effect of GABA. They actually perpetuate GABA, or they will simulate GABA to induce a state of altered mental status or decreased awareness. So this is going to be the last slide that we're going to go over for this session. So seizure prophylaxis, long acting. We talked about Keppra, and here's your dosing. Phenytoin or Dilantin, and here's your dosing. And then you'll see with fosphenytoin, it's dosed as 15 to 20 milligram PE, and that is phenytoin equivalents. Okay, and so that's just how it's calculated. It's a dosing that is essentially equivalent to phenytoin. Daryl, what manual do you prefer to use? Well, let me show you the manual that I use, Daryl, and it's the one that I've mentioned in the course. And it's actually the Critical Care Transport second edition. This is from the American Academy for Osteopathic Surgeons. This is the second edition, and this is the one where there have been some typos. Of course, you can never expect every manual to be perfect. This is probably the primary manual that I use for studying, as well as for writing the course. This is the one that the Board of Critical Care Transport, one of them that they suggest as a primary resource. There's a handful of other ones that are really great. Back to Basics is another great book for questions, kind of getting used to the type of questions that you'll see on the exam. What else? Of course, the airway section I primarily referenced. The Ron Wall's Manual of Emergency Airway Management. This is a fantastic book. Of course, then there's all your standard Brownie Button badges, your Brownie Button certifications. So anything related to neonates is going to come out of the neonatal resuscitation book and the stable book. HIROB is going to be covered a little bit, or high-risk OB patients is going to be covered a little bit in the NRP manual. What else? Advanced medical life support. And then I guess this is probably another one that was really popular for a while. This is the Air and Surface Transport Nurse Association Patient Transport Principle and Practice. This is still referenced as a primary manual. So that's another good one as well. I mean, I could just go on and on with all the textbooks that I use for my studies. But those are probably some of the biggest ones. Of course, there's the the Will Wingfield book, the ACE Prep. That one's pretty good, although it seems to be getting a little outdated. I know that he's working on updating that course, but it's been a slow going process, and I know that he's kind of moved on to other things. And so that's actually one of the main reasons why I wrote this course, or I'm writing this course, is because I felt like there was a lot of new material that wasn't being conveyed in some of the more recent courses. Plus, who else does things like this, right? Okay, so that's going to be it for today. I'm going to try and do, let me stop this sharing real quick. So stop sharing. So I'm going to try to do these office hours on a semi-regular basis, probably every Tuesday. Can't guarantee it's going to be every Tuesday, but it will definitely be in a fairly regular basis. Each time I'm going to be broadcasting right here in the EPICC Review course, Student Center. So let's see. And I will send out notices. I'll try to post kind of in the Student Center an announcement that I'm going to be doing the office hours well in advance. This is kind of my first go at it to see how it works. If you like this kind of thing, if you find this helpful, if you think kind of going over this in a more kind of casual environment is useful, great. I know that there weren't a lot of you that popped in during the broadcast, and I understand that it can be a little tricky in the middle of the day with people, people having obligations. I'm going to do another office hour session tonight at 9 p.m. Mountain Time, 11 Pacific. I'm sorry. 8 Pacific, 11 Eastern. So hopefully I can catch more people. If not, if you are just catching this on the replay, you can leave your comments there on the replay page, and I will comment there, and I'll get back to you, and then I can answer those questions in a future office hours. So another thing that I put in the announcement for the office hours was that if you are not going to be able to make the office hours, but you do want something answered during office hours, you can always leave a comment in the post that I put in the Facebook group, and I will read those before the office hour session starts, and then I can try to answer those when we first get going. The last couple things that I wanted to go over, if you have not checked it out already, is the Tips from Crit. Tips from Crit podcast is here. Session episode 5 went out last Tuesday, and I was hoping to get another episode in before today, but that didn't happen. But in general, I'm going to be trying to put these out every Tuesday. I have been getting a couple questions recently that I can use in the podcast. I've got a ton of really good questions. Few of them are audio. So if you have a question that comes up from this office hour session that you would like mentioned in the podcast, you can head over to askflightcrit.com, and that will take you to this page. You click right here on the blue tab, and that will start recording a message. You can see here it's going to start recording right away because I've got the tool on my computer. You can do this from your smartphone or from your computer. You can also you can click right over here on the actual button on the Tips from Crit website and send me a message right here as well. And then I can include that in a future episode of the podcast. That, I believe, is the last thing that I have. We are getting close to the end of the year. I can't believe it's December already. Pretty exciting. I am going to be having a like I said, I'm going to be continuing these office hours on a semi-regular basis, continuing through the end of the year, except around Christmas. We are going to be out of town. I'm taking my family out of town for about a week and a half, right around Christmas. But I'll still be able to pop in and answer questions from time to time, and then we will pick back up after the first of the year. So next week, we'll have office sessions. The hours may be a little bit different. I'm taking my CNPT, Certified Neonatal and Pediatric Transport certification exam next Tuesday. So wish me luck on that. And then we'll probably have one session later that evening, next Tuesday, and then the following week we should have 2 sessions again. So thanks everybody for tuning in. I hope this was helpful, and can't wait to hear your questions. I guess that's all I have for now. We'll talk to you next time. See ya.